what happens when an expert speaks before an expert. So anyway, let's go through this quickly. I hope that after my presentation, all of you would feel that you can manage adolescent mental health issues in clinical practice. Because if we do not have this approach, we know that if we do not manage these issues in adolescent, they can lead to an emergence and re-emergence of non-communicable diseases and other mental disorders in adulthood. So in the next few minutes, I'll go through a few practical pearls, talk about the influence of COVID-19 on adolescent mental health, and what is the role of pediatricians in mental health issues. Now, coming to a few practice pearls right in the beginning, important thing for us to develop a adolescent friendly clinical practice. It is good clinical practice that we as pediatricians begin to see any child coming to us over the age of 10 years, a few minutes alone, even in a busy OPD. It could be even for a few seconds. This would convey to the parents that all adolescents do spend some time in private with their pediatrician, and this would help you to build up rapport and therapeutic alliance right from early adolescent age group. The second thing is, it's a good idea to have a few hours, probably on one weekday, exclusively kept for adolescent practice. Of course, the inclusion of head psychosocial history into your clinical weaponry. Also, when you discuss the management, remember to discuss it first with the adolescent and then with his permission with the parents. And important to partnership with the parents, schools, peers, and also other adolescent health professionals and mental health professionals and professionals from other specialties. So as Vijay said, that normative psychosocial development can sometimes confuse and present as a mental health issue, as it did with this adolescent who was 13-year-old, and the mother was absolutely aghast. And she said, look at this doctor, he come from such an orthodox family, he has punctured his ears in multiple area, and now he wants to actually pierce the other ear. What should I do? So very coolly, keep calm and then answer is the rule in adolescent medicine. I told her, please refer him to a place which really follows sterile injection techniques for piercing. She was totally shocked. She said, and what do I tell him? I said, just ignore the piercing. And though she did not agree with me at that particular time, thankfully she followed my advice, and the adolescent had all the earrings out from both the ears within the next few weeks. We must understand that adolescents undergo an identity crisis. And in this case, it was a physical identity crisis. And when the adolescent got bored with this experimentation with the appearance, he just took them off. But in case the mother had reacted, it would have created a war at home. We all understand about head psychosocial history. Its importance is not only in picking up what Vijay said, the strengths, weaknesses, but also comorbidity and risk and protective factors. Because we know that the individual, himself or herself, the school, the peers, the family, community, the government, the governmental policy, and media all affect adolescent health and well-being. Let me explain this with an example. An adolescent with learning disability and attention deficit hyperactivities disorder goes to a school where he's abused by the teachers. He meets a gang of friends who drink and smoke, and so does his father. The community does not have any facility for remedial education or adolescent-friendly health services, and the community also encourages the use of alcohol, and so does the media. When this adolescent becomes an adult, he lands up in jail after robbing a bank, and he had dropped out of school just at the age of 15 years. So you can understand this collection of all risk factors have actually push this adolescent into risky behavior. Yes, research has proved again and again that parental and school connectedness, religiosity, and spirituality are the strongest protective factors and have to be encouraged by all pediatricians. Another girl which was brought by her mother, by her father, and he said that my 16-year-old daughter has frequent headache and has become aggressive. Since 3 months, there has been a fall in academic performance. There have been fights and generalized aches and pains. So what do you think? Is it just normal adolescent behavior, or is it the onset of a mental disorder? Look at these points. Whenever there is aggressive behavior which is out of proportion to the development and it has been lasting for more than 2 weeks with affecting the functioning of the adolescent, definitely is a flag sign of mental disorder. But look what happened. When I talked to this adolescent in privacy and confidentiality, when I talked about H the home, she said, my mother has mood swings, she has rage attacks, and they were all pointers towards bipolar disorder. When the mother was referred to the psychiatrist under treatment, she felt better, the family felt better, and the aggression of the 16-year-old simply disappeared. So as a pediatrician, have your antenna up to pick up mental disorder, marital disharmony in the parents, and refer them accordingly. Another child of trichotillomania, a 14-year-old, and the father said, look at him, what is he doing? After I talked to the child, again another case of attention deficit hyperactivity disorder with learning disability. The father was an IITN and was forcing him to actually go for IIT coaching, which the child hated. He loved football and he was missing his football coaching. The father was a very authoritarian father. Actually, I partnered with the mother and tried to convince the father after 6 months of football coaching and parental coaching and remedial education. Look at the crop of hair. This is not the picture of my patient because he refused to get photographed. This is a picture picked up from the internet, which really looks just like what my patient did. So remember, partnering with the parents actually reaps rich dividends. Coming to the next practice pearl, rule out organic disorders. As a pediatrician, remember, anemia can mimic any mental health disorder. So if you can't do anything much, please treat anemia. 40% of our adolescent girls are anemic and 18% of the adolescent boys are anemic. And yes, needless to say, in mood swings, rule out hypothyroidism. This 11-year-old girl presented to the clinic with irritability and severe headache for 1 week. When I did a general physical examination, I found that there was conjunctival suffusion and there was a squint. So I referred her to the ophthalmologist, who laughed at me and said, oh, this is just corneal drying. Put her on some lubricant drops. And after 2 days, she came back with severe headache and I felt the squint had worsened. So I changed the ophthalmologist. And in fact, I rang up the previous ophthalmologist and told him, and he joked with me and said, Preeti, you are missing a psychosomatic disorder. I was sure about my heads. It was not a psychosomatic disorder. It was not a somatoform disorder. The second ophthalmologist did an MRI and it turned out to be medial rectus cysticercosis. So be good with your clinical examination, be good with your clinical history taking. Please remember, all headaches are not indicative of somatoform disorders. The next practice pearl is you must rule out associated medical disorders like diabetes mellitus may be associated with depression. Important to manage both the physical and the mental disorder properly to really get good clinical results. ADHD, autism, learning disability, these all disorders should have been picked up much more earlier in childhood. And yes, they can be associated with comorbidities like depression, anxiety, even eating disorders and suicidal behavior. Also, remember that some disorders like urinary tract infection, especially recurrent urinary tract infection, may be a flag sign of sexual abuse. Recurrent vaginal discharge may be a flag sign of sexual abuse. Have your antenna up because you know that reporting of these cases is mandatory according to the law. Please brush up your mental status examination, brush up the technique of looking for orientation, appearance, thought, judgment, speech, perception. Please brush them up, because we know that any problem in thoughts is probably indicative of psychosis, and the child has to be referred to a mental health professional immediately. Useful to have screening tools in your private practice. These screening tools could include Beck's Depression Inventory and Patient Health Questionnaire 9 for depression, screening for childhood anxiety-related emotional disorders, the SCARE tool for anxiety, screening to behavior intervention, and CRAFT tool for screening for substance use disorder, ask for questionnaire for screening for suicidal ideation. And remember, all these are screening tools to just indicate towards a diagnosis and to follow up the patient and check the response to counseling and clinical intervention. Actually, these tools have to be later, the findings have to be diagnosed. The gold standard is DSM-5. So according to the diagnosis, you will plan the pharmacotherapy and also the psychotherapy, and referral indications definitely need to be kept in mind. This is another example of a screening tool which has just 2 questions. Please have a look at this. It is called the Patient Health Questionnaire 2, and it has a great sensitivity and specificity for detecting major depression in adolescents. I would recommend all of you to read this article, which is freely available on the internet. It will give you a lot of information about heads and also about Patient Health Questionnaire 2. And another tool I would discuss in a moment. This mother got her 18-year-old son, who was preparing for IIT, in shock because she had detected this. And what is this? Marijuana in his bag. And she was absolutely shocked with this. And when I talked to this young man, he said that yes, he was under a lot of stress and under the influence of his peers. To really combat this stress, he had taken marijuana just twice or thrice in the last 6 months. Now, there is an excellent tool which is called Screening to Brief Intervention tool, which has just 1 question. In the past 1 year, how many times have you used tobacco, alcohol, marijuana? Stop if it is never, otherwise you have to continue and ask for other hard drugs. Now, if the adolescent says never, how will you clinically interpret it? If the adolescent says never, it means no substance use. The adolescent here said, I have used it only 2 or 3 times. It means there is no substance use disorder, but yes, there is substance use. If the adolescent says that I have been using it monthly, it means there is mild to moderate substance use disorder. And if the adolescent says I have been using drugs every week or more often, it means severe substance use disorder, and you have to refer this case. Luckily for us, 95% of the adolescents who use substances are following in these 3 categories. So what did I do for this adolescent? I told this adolescent, I can understand your need and your desire to join the IIT. Do you know marijuana has a direct effect on your hippocampus and prefrontal cortex, which will affect both your judgment and memory. And at this time, you want your brain efficiency to be topmost. I further said, for your stress management, I have this stress management pamphlet. And this was the brief advice which I gave him in just 5 minutes. And I said, I'll be happy to see you again in the adolescent clinic in the next few days. So this is what a practitioner can easily do in his clinical practice. And this young man did not get into IIT, but he got admission into RV College, which is an equally good college in Bangalore. Now the last case. I came back from my clinic one day and I got a phone call, and the voice on the other end said, Doctor, I'm standing at the edge of my balcony and I'm going to jump. I must tell you a little bit more about this case. Actually, this young girl had come to me a few days ago. And by the way, this is an imminent risk of suicide, and you have to do an immediate referral to the mental health professional. As a practitioner, what do you do on the phone? Can you refer this child to the psychiatrist? Then I'll come back to that again in a minute. So she had come to me a few days ago, brought by her mother. The mother said she had been on antidepressants for the last 1 year, but her aggression continues. The doctor feels that her psychiatrist feels she does not need any more antidepressants. Doctor, I want you to help her. What she needs is behavior therapy. Even the psychologist has given up on her. I talked to this young girl and I understood that there was a lot of sibling rivalry. I called her for another appointment the next day, but she refused to come. And that is the time, after a few days of that, I got this call from her. And I told her on the phone what happened. She said, doctor, you know how my mother is. Today I was talking to the next door neighboring boy. And when I came back home, she said, I am a prostitute. Come on, doctor, if your mother says that you are a prostitute, do you think life is worth living? Remember, she had 3 suicide attempts before, and she was hospitalized for all these 3 suicide attempts with a history of prolonged depression. Then I told her, if you have a 100 rupee note in your hand and if you crush it, what is the value of the note? She said 100. And I said, so what do you think now? And she was intelligent. So she said, so do you think I should talk to my mother just now? I said, please do. If your mother thinks you are a prostitute, that doesn't make you one. You know what you are. So she said, my mother is in the bedroom. Should I go there? I heaved a sigh of relief. All I wanted her was to go away from the balcony to the bedroom. So she gave the phone to her mother, and I just told the mother, don't leave your child alone for today. Just talk with her and listen to her. Don't speak a word, just listen. And that set the pace of unconditional love, assertive communication, and counseling with the mother, not with the adolescent. I never saw the adolescent again, and I counseled this mother for nearly 1 year. This extended to telephonic counseling for 4 years. And now, just a few weeks ago, I got to know this adolescent is happily married, a chartered accountant, and planning to go abroad. So the last practice pearl, which I want to share with you, is counseling and partnership, and a toolkit for well-being of the adolescent, which can be used in all cases, really all cases. So we already know about this approach. What is actually counseling? Counseling is not telling the patient what to do. It is allowing the counselee to choose his decision and to help him to implement his decision according to his psychosocial, spiritual, and financial needs. Let me share with you this case of a 14-year-old brought by his sister, and the sister said, please help my brother. He goes to a red light area. And I talked to him in privacy with confidentiality and followed the approach. I listened to him. He said, I have nobody to talk with me. My parents are international lawyers. My sister is busy. I have nobody to talk with me. And that's the reason why I go to the red light area. So then we talked about the risks of the red light area. We talked about with whom could he talk? Could he talk with his other friends? Could he talk with his maid servants? Could he talk with his cousins, extended family? And he refused. He chose to go back to the red light area. I could again explain and review the key points. And what do you think I did next? I talked to him how to wear a condom the proper way. Remember, in adolescent medicine, if you can't do harm elimination, you have to work towards harm reduction. Keep the windows and doors of your clinic open. And yes, I asked him to come for follow-up because this child, in spite of wearing a condom, may still be prone to STI, and we need to really follow up this child very closely. So what is the stress management toolbox? Vijay has already alluded to it. Yes, talk to them about balanced exercise, eating healthy, sleeping for at least 8 to 9 hours, prayer, meditation, annual health checkups, immunization, problem solving, life skill, healthy media use in this time of COVID. Yes, stay away from physical distancing, but social closeness should increase. Use your study skills regularly, have a connect with nature, be grateful, help the grandparents at home, and yes, pursue your hobbies. What do you tell the parents? The toolkit is follow the authoritative style of parenting. Do as I do. Madam already told about role modeling. Stay away from authoritarian, uninvolved, or permissive parenting, or helicopter parenting, or snow plowing parenting, because this will make the adolescent very much dependent on you. What has COVID done? COVID has actually increased the mental health issues. In this survey, which we conducted in around 500 school students, 50% said yes, they were affected by COVID. Another 50% said they were not. Out of that, 25% said that life was better. Most of the problems indicated a problems with being online, also an indication towards anxiety and depression, even online. Please remember that if you can develop a nurturing relationship with one trustworthy adult in their life, this is protected. And this is what the research says. What about me personally? The tele mental health services, which I have been doing, I have done 74 teleconsultations in the last 6 months. And no surprises here, the maximum have been for increased media use and poor motivation to study. How do we prevent mental health problems? This is the key. The annual adolescent health visit. We must be up on it. We should know what to screen and what to do, both for physical health, mental health, psychosocial health, and emotional health. What is the role of pediatricians? The role of pediatrician is beyond the clinic. It is to go into the community, to take up school programs, to advocate even at the governmental level for adolescent mental health. Yes, there is the RKSK, the National Adolescent Health Strategy. If you get an opportunity to join this strategy, go for it. Implementation has been an issue in India. What is the framework for child and adolescent mental health services in LMICs? This is what we did from a recent paper. It is not only about doctors, it is about peer educators, teachers, community health workers, digital mental health services. Yes, on the top are child and adolescent mental health professionals. Seize the opportunity to make a difference, because if you wait too long, you will miss them. I wish all of you a very fulfilling adolescent clinical practice. And yes, you can.
Thank you so much, Dr. Preeti. It was a wonderful, excellent, exhaustive, and extensive session on the mental health issues by Dr. Vijayarani and Dr. Preeti. So nicely, aptly, and so wonderfully dealt with all the aspects. So nice.
Thank you.
There are no questions. We'll go to the next session. This will be the topic will be lifestyle in adolescence, a very important topic. This will be dealt by the expert, Dr. Newton Lewis. He's from Kerala. He's a wonderful, very practical adolescent